This work was funded by HRQ, and this is part of stuff that I've done with a team of investigators back at New York State. My colleagues were at Weill Cornell and also Mount Sinai, respectively. And actually, this paper just got published. So this is kind of the presentation format view of this research. So what is health information exchange? Just broadly, the goal is to take information from one provider and move it to another. So our doc here, who's on your left, who's clearly a fan of the late 1980s, has his Commodore 64 and is interested in taking some information that he has and passing it over to his colleague on the right with the MacBook. And I realized this morning, the beauty of using stock photos from the internet. This man has what appears to be about 2 pounds of weed on his desk as well. That's not really relevant to exchange processes, but it's the idea. You can move information from one provider to another, no matter what kind of services they're providing. Now, that's a high-level concept of we just want information to move. That's what health information exchange is, and you can accomplish that many different ways. I'm going to talk about 2 ways, and these are kind of the 2 predominant models. The first is what we call directed exchange, or AKA push, right? It's the idea of mimicking the good old-fashioned fax. And I say good old-fashioned fax, even though most health organizations still have plenty of faxes around. This is the idea of information automatically coming to a recipient through the initiation of the process by the sender. So if you are, think about good old-fashioned fax or even your own email, you're not necessarily saying, hey, I wish somebody would send me an email or going out and asking for it. It's dependent upon the sender. The sender is sending this to you whether or not you asked for it or not, and it's coming that way. And it's automated, generally, that process. The other approach is kind of the conjugate. It's called query-based or pull. And this is the idea of the end user going out and searching for records. They'll go through and they're the ones who is initiating the information request to come back to them. So they are complementary in the sense of they are fitting 2 different types of potential workflows and 2 different ways of looking at it. Now, we have those 2 approaches, and there's obviously a whole bunch of technological stuff behind it that we're not going to get into, but we're going to kind of focus more on their philosophy. Now, both achieve the goal of information sharing. We can move information from one provider, one hospital to another through either one of these mechanisms. Information will move. Actually, in doing that, both will meet federal policy requirements. If you have to meet the expectations of the old-fashioned High-Tech Act and now what's under MACRA, if you need to move information, you can move it through either one of these approaches. That will be fine. And it's interesting enough, in the literature, there was a little bit of debate around this in the informatics space about which approach is better, or how do they actually function. And there's been a couple thought pieces out there that say these are complements, that they really work together to really meet people's information needs, and that we should be doing both of these. However, that's kind of what the assumptions are, but they're not really grounded in anything empirical. The assumptions that they work together is not built on any empirical study, or the fact that they even function in a complementary manner isn't. And the kind of anecdotal and real world, I would say, scuttlebutt or commentary actually indicates that they may not be all that working together as well as we think. So for one thing, on the directed space, there's only a limited amount of research, both survey-wise and qualitatively, about provider preferences. And if you ask providers which one they favored, at least in these surveys, people say, I don't want to go search anything. I want to be pushed the information, right? So there's a clear provider preference for one over the other. And oddly enough, even though federal policy and strategic plans from our friends at the ONC say we love all types of information exchange and we don't care, they managed to only write directed exchange into the certification requirements. So by federal policy requirement, they've actually promoted one that said, thou shalt do this. You have to do it. On the contrast side, for the query-based exchange, that doesn't exist. You could have an electronic health record that meets certified meaningful use requirements without having any ability to go out and search. That was not a requirement, but the other one was. And if you went out and talked to people who run health information exchanges, particularly a few years ago when this was becoming this controversy was kind of coming up, particularly around certification, many of them were running what were effectively query-based systems, and they would say that they viewed the directed approach as a competition, that it was something that might undermine their models. And so there was this kind of, yes, they should work together and they could work together, and we think they should, but that's not based in any hard science. And if we kind of scratch the surface a bit, we have this underlying current that they're actually not really functioning that way. So that led us to these questions. Kind of in the absence of empirical evidence, we were interested in three things. One was, do health professionals use one more than the type in the other? That hadn't been quantified out in the literature. We were interested in, if you had directed exchange, was it actually a prompt or associated with usage of query-based exchange? Did they work together? And what type of patient characteristics or provider characteristics were associated with usage of each type? So we're going to do this study in, we did this study, we're not doing it. We were in 3 federally qualified health centers serving Western New York State. We had 3 years of data, and we had about 240,000 adult encounters at these FQHCs. The data sources we're using from these FQHCs is their EHR reporting platform. These FQHCs are all members of the same health information exchange organization, but they had another neat feature. They were part of a quality improvement collaborative along with other FQHCs, and that quality improvement collaborative made a deal with them. They said, look, if we will let you measure us and do work with you and help you out, we'll give you technical assistance on your electronic health records. And so they said, fine. And they all ended up buying ECW, and this quality improvement put a reporting platform called Bridget over the top of this ECW instance. And so they were able to extract out every single click user activity within the EHR. So we're able to actually look in and say what data was brought in through directed exchange into the EHR, and whether it was actually pushed to you. Did somebody actually go in and open it and look at it and do anything with it? And we're able to get a lot of detail on all the encounters. We marry that up with the Health Information Exchange organization that these 3 FQHCs were participating with. So we also know, okay, through this reporting platform, did you click to go look for information that was pushed to you? But then did you also go make a query or a call out to the local health information organization to pull information as well? And we have those log files and we're able to measure them off. For those of you who are interested, it was at this time a standalone web portal that had no single sign-on for the exchange. And just as a brief aside, the world in New York State in terms of health IT has been very different than the world in Indiana, right? I'm looking at John. John knows how this is different. In 2004, New York State passed what they called the Heal New York Act, which basically put a lot of money into health IT. If you think back to 2004, New York looked up at Massachusetts. And if anybody knows at this time, what was Massachusetts doing? Mitt Romney was inventing Obamacare, is basically what Massachusetts was doing. Yeah, that's true. He wouldn't admit it, but that's what he did. And so New York State was looking around saying, hey, Massachusetts making this great splash in healthcare, what could we do? And somebody sold the state legislature on IT. And so the state of New York since then has put in about nearly $1 billion into health IT infrastructure. And early on, they set aside $150 million to establish regional health information organizations, or these small continuous area health information exchanges. Rochester was one of them that was established in 2006. So by the time we come along and do our study, they've been operational for 10 years. So they had been doing a lot of development, but New York State has multiple ones operating across the state. All right, so what are we gonna do? So we structure our data file to look for instances both of directed exchange, this push, and query. We took encounters, and we took from the patient's encounter, we look back to their prior encounter to create a window of to say, hey, within this window, had anybody sent you laboratory information, imaging information, or some other kind of clinical document? And these could be discharge documents, these could be some sort of note, right, or other kind of report. We also looked in the same window, did you query the exchange for this particular patient? And we have everything linked by timestamps, patient IDs, user IDs, and so we're able to make this up perfectly, link up all the data in that way. Now we have this kind of ambiguous look back period because we know based on qualitative research and workflow, it's not just simply, oh, you know, Tony is my patient, I look at Tony, and then I start going gathering information. It doesn't work that way. Sometimes I may have a staff member look the day before to go pull some information. Maybe if labs are coming in routinely the week before, I'm having that stuff processed. So we created this window to do that look back period to come through. And then we're going to have our independent variables are going to be driven by a very socio-technical approach to thinking about health IT. And in this approach, it says, you know, technology is great, but technology is only really used when it fits within the organization. Like it has a high level of congruence. And we're going to look at congruence between the individual, which is the different type of provider who's using it, about the task. And so generally this is about like, is the task really complex? And so we calculate out several things that are kind of related to complexity that might influence whether or not somebody uses technology, whether it's like diagnoses, comorbidity scores, you know, was it a scheduled same day appointment, those kind of things. And then the overall kind of technology context. And what we do for that is almost this kind of idea of a peer effect, like how much other usage is going on within your clinic at the same time. Like, are a lot of people using the query-based exchange or is really not? So this kind of idea of, we have this culture, this idea that we should be using these technologies. All right. So our first question we're going to ask is directed usage associated with query-based usage? And this is just a cross-sectional analysis, and we do some logistic regression modeling. And our outcome that we're interested in is, did you query yes or no? That's really it. And what we ask is, where you have three kind of parameters here, whether or not you had information pushed to you that was a lab, information that was pushed that was an image, or one of those documents. And I should have mentioned, we're able to distinguish things that are pushed to you because you ordered them from things that are shared with you because you didn't order them, right? So labs that I ordered as a provider that are coming back to me are not pushed, right? That's not cross-institutional or inter-organizational exchange. That's just me getting information I already had. We're able to several those out. We also then are going to have our task, technology, and individual measures from the fit model, and we do some fixed effects to control for the clustering. What we're really interested in this model are these three parameters. If they're positive, that means the two systems are working as complements, right? I got one, it increases the odds that I'll go look in the other. If they're negative, it means I got a lab, and that actually decreases the likelihood that I'll go do the query-based system, which would be, you know, contrary to most of our expectations that are based on policy. All right. For our next analysis, we were interested in which patient and provider or patient and visit types were more likely to have each type of exchange. And so instead of just having query-based as our outcome, we're going to take query and directed and combine into a multi-nomial logistic regression with a categorical outcome. Again, it's a cross-sectional, but we're going to look at, with a reference against no usage, did they use directed only, did they use queried only, or did they use both? And we're going to control for everything we can with fixed effects as well. All right, so overall, what was the most common thing? In about a quarter of all the encounters, there was some kind of directed information exchange coming into these FQHCs for these encounters. That's, to my knowledge, I haven't really ever seen that number anywhere else in the literature about how much information gets pushed in or how frequently it is, but that's reasonably believable. About 3% of the time, they went out and queried in advance or associated with that patient encounter. That's actually fairly consistent with the literature and how often querying occurs, particularly in an outpatient provider setting. About a little bit of time, they were using it both. It's not the most common thing. So what was associated with using query-based exchange? So if we look across the top here, here's our measures of directed usage for labs, imaging, or other kind of documents, and usage of directed exchange for imaging and for clinical documents was positively associated with query-based exchange. And we have the positive coefficients, and we have our marginal effects over to the side. And so in that instance, yes, if I got a imaging or if I got a discharge report or some other note through the exchange, I was at a higher odds of going out and using the query-based portal than if I hadn't got them as well. So controlling for all other factors, we actually do see this complementary relationship. Now turning to why did people use it, or in what circumstances, this is our multinomial outcome of whether against all use, against no usage or the type of usage, so we have directed, queried, or both. We could see the one that has the strongest, and these are marginal effects for each one. We could see the one that has the largest is if the visit was associated with a post-discharge or a post-emergency encounter. They were much more likely to get directed information. They were much more likely to go out and query, and they were much more likely to do both, right? And I think I saw a couple nods of the heads from some of our clinicians in the room. That I think that makes sense, right? This is a context where we have a clear indication that information that is possibly very relevant to this visit is somewhere else, and we need to have it move over, right? We see a couple other indicators of, more like complex patients could have a lot of stuff directed, pushed in, and that also makes a little bit of sense as well. People who might be relying on specialists, but that's a little more challenging in this FQHC population. But generally we see in this one. So we thought that was interesting and useful, and so we decided to layer on a little bit of qualitative work to put a little color on what we were finding. And we did interviews with some end users, and they were generally supportive of what we saw in the quantitative stuff. I'll just read a couple of them about why things might drive them up. So sometimes the discharge summaries don't have everything. The discharge summary will reference a consultation report that they didn't send, and I'll go out and get that. Sometimes there will be labs pending, and by the time I get the discharge summary, the labs are complete, and I have to go out to the RIO, that's what they're calling their exchange, to go get it. As you remember, documents were one of the bigger drivers of needing to go out to get more information, and that makes a lot of sense, right? It prompts more questions, or it wouldn't always be complete given the timing. This nurse responded, "Oh, the patient has some labs done, not ordered by us. I wonder what's going on." So we'll look and find they were seen in an emergency room 2 days ago, and we don't have a report from the hospital yet. So that'll prompt us to go get more information. Again, this idea that being another type of information could trigger them to go out and search more. We have another one. There was an abnormal lab, and the physician wanted me to figure out why. Where did it come from? What's going on? Why were they hospitalized? What happened? Labs, as a non-clinician, I'm going to make an assumption, lab information is probably valuable. However, it's not always got the context and complete story that comes along with it when you get the value and the information. Something like a query portal where it can get a broader set of information might be able to fulfill in those knowledge gaps. So you can see why it would drive that. But again, within the context of this didn't happen all the time, so you can see why this would not be sometimes of a less routine experience. And so what did we see? Well, overall, we saw health professionals use directed exchange much more frequently than they use query-based exchange. Query-based exchange usage is associated with direct usage, especially for imaging and clinical notes. Those were the two that prompted. I think the fact that laboratory wasn't as common makes also some kind of sense as well, because there's just so much kind of, I guess, routine and common information in there that it may not necessarily prompt that kind of finding. And HIE was used more frequently for patients who had recently been discharged or who had an ED visit. Again, clearly indicating that need to facilitate information across transitions of care. And so with that, I will pause, or do more than pause. I'll actually stop and ask if folks have questions. or comments? Oh. Sir. Okay, John.
Mostly, I just didn't want you to not have any questions.
I appreciate that. It's very considerate of you.
And sorry if I missed this on the way by. In terms of use of directed exchange, were you able to capture the difference between provider got something pushed to them and provider actually used the thing that was pushed to them?
So the question was, are we able to distinguish between something pushed to them and something they actually used? So yes, for the qualification. So we just didn't take actually, so in this particular EHR model, a directed message, no matter what it is, goes to what they called the holding tank. It's like not immediately brought into the record or put into a space. People have to go out and review it and say, yes, I want to take this information in. We limited ourselves to the information that was actually clicked and said, yes, somebody took it in and gathered it. So I'd have to go back and figure out what proportion of that information was that stuff was pushed but never actually was utilized. And I'm using utilized very roughly, right? Like the idea that somebody clicks it and says, yeah, put that in the record or put that in for me to be able to review later. There's many more steps before that actually getting put into somebody's cognition and applying itself to care, but it's about as good as we can do to say somebody said, yes, I want that data and touched it. And so we limited to that, yes.
I'm really guilty of oversimplifying everything, so apologies. But it seems to me that I infer that the more we can place value on directed information in there that's already there and actionable, the more we can separate ourselves and justify why the HIE is so damn important. That I feel like so many people still like, why do I need an HIE? We all know that's not the case here, but so many people do that, and I feel like this might be a really great thing to start. Like, how would this be different than exchange between Epic and Epic or Cerner and Cerner, where there's no directed exchange? Can we start overlaying value between the two so we can maybe start to put that conversation to bed?
Yeah, I'm glad you kind of brought that up. That was one of our kind of policy recommendations and conclusions is, look, clearly there is value in pushing information, but it doesn't meet everybody's needs in every single instance. Policy should at a minimum be encouraging both, and technologically it should be just as easy to get information through both venues in order to get that complete picture. Because if you just say one is enough, that's clearly not the case, because you need to have the other to fit with it. But policy doesn't necessarily support that, so it would be more effective if it did. Sir.
And it gets really interesting really quickly. Two comments to support that statement. One is the Regenstrief Institute, CBMI, understood that 23 years ago or whatever, when they invented 27 years ago, when they kind of invented CareWeb and the INPC, because we've had trouble characterizing the way it works as push or pull, because we auto query, right? That's how it's set up. Is, well, we think you are probably going to want to have this record, so we're not going to wait for you to query for it, which I think is really a smart way to approach it. Meanwhile, the way Epic is set up is they have incorporated something that they call auto query, but it's not auto query for the data, it's auto query for the answer to the question, is there data? And so understanding that it's hard to get clinicians to query, they're trying to at least give them that key piece of information as, well, there's something to query there.
Yeah, and there's thanks, Sean. There's also technological things that could be put in, like pre-populating, again, that kind of auto querying, putting notification, obviously single sign-on, making it one click, no problem, putting some sort of consolidated view, putting a icon or badge that flags in and says, hey, this information is available. Those sorts of things can all facilitate to make that, to alleviate the fact that querying is generally always end user initiated, to help them make that initiation, right? So that can be done. Sir.
So, that's loud, sorry. So in this, you were looking at three specific sort of use cases where information was pushed. I'm curious, from your qualitative interviews that you did, were there other things that triggered clinicians to go out and do a query?
Yeah, so in this case, our work was mostly, we really honed in on in reaction to information. We didn't get it broader, right? But I think the consensus was, and I think this does fit with some of the broader, that there's known that something relevant is missing, right? Like whether that indication comes from the patient, that they've been lots of different places, whether that indication comes from the documentation that indicates that, okay, all of these labs from their discharge are still pending, right? Something that, some kind of indication that there's more information out there that is highly relevant to the decision maker is one of the big driving process. Now, the definition of what's relevant and how much and what's the driver to actually initiate that, that's kind of a gradation, of course. So I think the answer to your question was no. All right, well, I thank you all, and I'm going to get out of here now.